everyone. We might have a couple of people joining, but forgive us if the door opens a little bit. It's lovely to see you all. There we go. Lovely to see you all. Thank you for joining. Hope you've had a really good morning. So really what we're going to explore in this session is we're looking at embedding a health inequalities approach to recovery. I'm Durka or Durka Dougall. I'm the Chief Executive of the Centre for Population Health, and I specialise in public health, population health and tackling health inequalities. Joined by a fantastic quartet of colleagues on the panel, and thanks in advance to our NHS providers colleagues who have just been fantastic in setting up the session. So I guess why are we here? Why are you here? And I know you've started the conversation already in terms of some of this through the earlier sessions. So really, this session, we're going to go deeper in terms of some of those themes. And we're going to start looking particularly at how NHS organisations can really start to practically drive tackling health inequalities in recovery across community, acute, mental health and the ambulance sector. And really to not only look at what they've done, but how they've communicated the value of these approaches across their organisations and through, across and with partner organisations and communities also. I guess even before the pandemic, life expectancy improvements in England were stalling and there were stark health inequalities. We know that the pandemic shone a light and exacerbated those inequalities. And in particular, I think we all remember kind of some of the data and the headlines about the disproportionate impact of the pandemic on people in deprived communities, on people from certain ethnic minority backgrounds, both in terms of morbidity and mortality. I guess that really highlights and strengthens the goal for focus on population health and equity. And that's why they're key themes in the NHS. They were in the long-term plan. They are as part of ICS priorities. They're the top two, I'd say, of four. They're key elements of the delivery plan for NHS England and the 2023-24. And I guess they're also key priorities across our organisations where justice, social justice, fairness are absolutely paramount. But I guess the real question is, how do you do this? So in this session, we're going to discuss how NHS organisations have a vital role to play in leading, in leveraging that role for tackling inequalities through recovery, in really taking a lead in terms of systemic challenges and driving inclusion, equity. Our panel of speakers are going to examine what it means to embed a health inequalities approach to recovery, share their learning, and discuss some of this. Please remember that after they've given their input, there'll be time for you to ask questions. So do raise your hand when the time comes, and we'll bring a mic to you. We want it to be as interactive as possible to make sure that we get the most out of it for you. And at the end of the session, please do also scan the QR code and take the short survey to leave your feedback. So introducing our panel, who have I got beside me? And I can see amazing colleagues in front of me as well. But it does feel like I'm with celebrities. So let's go in order. So Professor Kiran Patel, so the Chief Medical Officer, Deputy Chief Executive Officer and Consultant Cardiologist at Coventry and Warwickshire NHS Trust. I've got Ruth Crabtree, who is Public Health Lead across Yorkshire Ambulance Services NHS Trust and also the Association of Ambulance Chief Executives. I've got David Bradley, who is our Chief Exec of South London and Maudsley NHS Foundation Trust. And James Wilson, who's Transformation Director across Mid and South Essex Community Collaborative. And I know you're going to help us to unpick what that means in a little bit. So thank you for joining us today. We'll start by asking each of you a question, if that's okay, and then open the floor. So Kiran, we know that waiting lists fuel inequalities. With the sustained levels of demand that we know our trusts are facing. How has your trust ensured that facing that demand doesn't widen inequalities?
Yeah, Durka, thanks. So thanks for the opportunity to speak this morning. I guess I would start that question with what you said about the pandemic and the fact that it really shone a light on inequalities. And when we looked at the patients who were dying during the pandemic, we brought home the stark truths that deprivation had a major impact. And in our organisation in Coventry, we looked at the postcodes of people dying and we mapped them. And it was the postcodes that were aligned to IMD 1 and 2. And I went off very early. I hope I'm not saying something controversial. Probably is. But no, I went off early in the pandemic and read a little book called Pandemic from the 1940s. And it said more people will die from non-pandemic related issues than the pandemic itself. So I started to look at this, and there is evidence, of course, as you said, that there are social gradients in access to elective and non-elective care. So if you're from a more deprived background, you are likely to use the front door of A&E as your source of healthcare rather than elective care. And conversely, if you're more affluent, you're better at seeking elective care due to health-seeking behaviour. So social gradients have always existed in access. And I got my Director of Performance and Informatics to say, let's look at those social gradients in the pandemic. So in April 2020, we looked at that, and they were far steeper. And I remember one afternoon looking at it. We've got a real problem. Those inequalities are going to widen if we don't do something about elective care. So to fast track what we did, I got my clinical leads together and I said, for 1 hour a week, I won't mention the word COVID, but let's brainstorm what drives health outcomes and what drives the inequalities that we're now seeing. And we managed to get together a range of clinical factors, but also social factors and operational factors that drove health outcomes. The factors about access to healthcare, right? How many times people attended A&E because they were on a waiting list, postcode, indices of deprivation, etc. And we put all of these factors together to help us to prioritise access to elective care, because we know that if you just have the same waiting time for everybody, that exacerbates inequality. And I'll very quickly explain why that is. Let's imagine you've got Norman from Nuneaton, this hypothetical, from a deprived background, lots of adverse childhood experience. By the time he's 20, he's going to have diabetes, hypertension, he'll be a smoker, and he's on a 0 hours contract. So when he gets pain in his hip, he just can't afford to take time off work. So by the time Norman gets to his GP and then gets onto a waiting list, he'll have much more advanced arthritis in his hip. He'll have a stormy course through surgery and he may not get back to work. And if he doesn't get back to work and he's the sole breadwinner in the family, the whole family spirals downwards. Contrast that to William from Warwick, who's a well-heeled solicitor, no comorbidities. When he gets his hip pain, he's likely to get to his GP very early on in the disease pathway. He'll fly through his orthopaedic surgery, he'll recover well and be back at work within a couple of days of his surgery. Both of those patients have had success in terms of an 18-week pathway. I put it to you that we've done Norman a disservice by not picking him up earlier. And that really worried me in our clinicians. So how do you correct that? How do you deliver the NHS constitutional standard? How do you deliver the NHS constitutional standard for everybody? Within that, clinically prioritise, but within that, make sure that the most deserved patient gets the next slot. And using the algorithm we've developed, we call it the Health Equity and Right to Treatment tool, HEART, just because I'm a cardiologist by background. But we're using that tool. We now prioritise our waiting list on a day-by-day basis so that it's more inclusive. So we've coupled elective recovery to inclusivity. Furthermore, whilst people are waiting, we have active waiting. So we tackle all the factors that drive outcomes. So we tackle all the prevention factors as well. So you get a better outcome. And by looking through the lens of inequality and inclusive recovery, we've narrowed the access inequality that really pervades the NHS at the moment. So in our specialties, 1 and 10 now we're at the same time rather than having the conventional 7 or 8 week gap in terms of the portal of entry. So we've made some headway. We haven't solved the problem, but we've started to tackle the 20% of what the NHS can do to influence health outcomes by configuring our services and the access to those services in order to promote inclusive recovery. And it's great to see that we're now starting to see the data behind this. Colleagues in Oxford, Barnsley have adopted the tool. Colleagues in Scotland are hoping to adopt it. So we're now setting up what we know works. And I think it's been a great exercise because people are starting to see that difference in health outcomes. So can it be done? I think the answer is yes. We've got to be optimistic. We can rise to the challenge and we can meet it.
Thank you. If that clap hadn't come, what I was going to say is personally thank you from me and probably on behalf of so many people for putting together some of the algorithms to actually start changing practice. So thank you.
I mean, I'd probably just add one thing, Dirk, that we don't stop here. We can apply clinical status reviews. So we heard this morning about people deteriorating on waiting lists. So we need to monitor that actively and move people up and down our waiting lists. And furthermore, I've seen Sean and James in the audience. We'd open the can of worms on social value judgments. So can you document whether people are not achieving what they want in life, going back to work or getting an education, because they are on an NHS waiting list? We can start to tackle some of those social value judgments, and we've got to open that can of worms in terms of debate.
Thank you. And I know there will be questions coming. We'll hold that and we'll move now to the ambulance sector, if that's okay, Ruth. So the headline after headline, and the reality is that the ambulance sector is under so much pressure. Level 4, unprecedented levels of continuous level 4. And I guess you've been doing really exciting work in terms of still looking and championing the role of the ambulance sector in terms of driving inequalities down as part of recovery. So can you tell us a little bit about your work and also about some of the challenges that you're facing in doing that, and maybe the things that you've done to overcome that too?
Yeah, absolutely. It's a really good question. I mean, we've been looking at how in the sector for a number of years. It really started back in 2017. We being the Association of Ambulance Chief Executives, published a consensus statement which was looking at how ambulance services can work more in partnership, more collaboratively, in that kind of preventative way. I think probably what I would say at that stage is that very much focused on the frontline aspects of public health in the ambulance service. And so going back to the challenges, that was a challenge in itself almost, really, because it was trying to carve out that role. And I think the more that we talked about it in the ambulance sector, the more we realised that there wasn't necessarily a well understood definition, I suppose, of what a public health approach actually looked like in the ambulance sector. And then obviously with all of the problems with COVID, we started to think, actually, okay, so what's our role here in terms of that kind of really upstream stuff? How can we move away from kind of the real focus on the front line and actually talk about some of the upstream stuff in terms of reducing health inequalities? So we went back to that original consensus statement, and we've reviewed that now, and we've renewed that, and we've published a new consensus statement back in June, which really, I guess, starts to think about, well, okay, what are the barriers, what are the challenges, but actually also what can we do to overcome some of those. So we've looked at sort of inequalities in access, experience and outcomes as a broad theme, but also in terms of the kind of the social determinants of health. So what can we do as anchor organisations to really work much further upstream and, as I say, take that focus away from the front line. One of the other things that we looked at when we were developing that consensus statement was actually some of the enablers, because we know that in order to be really purposeful in terms of reducing health inequalities, we've got to have that fully embedded in the culture of ambulance services. And I think it's probably fair to say that we don't yet, but we're on that journey, and some of those enablers I think will start to help us. So by enablers, I mean things like capacity and capability, because we don't necessarily have those skill sets in the organisation. Data, going back to your point, really, really useful. We know we've got lots of data, but we don't use it from a kind of public health perspective, and we don't look at it through that health inequalities lens. We're starting to do that now, and it's really, really interesting, the stories that we can tell with our data, but again, we need to do more with that. Strategic leadership, I think, is really, really important, and we are starting to see that come through, and obviously we need to have kind of board level support for this, but it's determining how we can really kind of get that accountability there, and the governance structures to really make sure that we're actually making the impact that we want to. So yeah, that's been really helpful, I think, to sort of structure where we want to go as a sector. And then obviously my role in Yorkshire is to look at how we can actually start to deliver some of that. And it is a challenge, but I think more so now than ever before, we're starting to see actually ambulance services really want to do something and do it well. So it's not paying lip service to it. And I think some of it now is, okay, we kind of understand where we want to get to, but how are we going to do that? And so for me, a lot of that will be around kind of embedding some of those enablers. And then if we can use the data to start to understand actually, you know, what does the need of our populations look like, exactly the way that you've done, actually we can start to say, well, what are the interventions that we can put in place as an ambulance service, and how can we work better in partnership with our systems, because we know that this isn't something that the ambulance service can do on its own. There will be things that we can do, but there's absolutely things that we need to work better in partnership with. So that's kind of where we are at a national level, and then looking at how we can implement that locally. So things like making sure it's, you know, front and centre in our strategies, that we've got a really good plan that sits behind that. Yeah, so early days, I would say, but really, really positive. And in terms of those challenges, it's keeping on with the conversation, keeping it going, and keeping it on the agenda. And yeah,
Lovely. Thank you. And I think there's something really, in terms of your work, that goes beyond even the ambulance sector, actually, which is in the workforce, the health and care workforce widely, that are so pressured at the moment and really strained. There's something about still, fundamentally, there's a lot of people who get the need to work differently and want to tackle health inequalities. So something about us as health and care leaders enabling staff to be doing this, and that may be some of what you're signalling in your work as well.
Absolutely, and I think that comes back to that capability piece. It's everybody in the service, because it's so cross-cutting. If you think about the anchor organisations agenda and the social determinants and the frontline elements, it cuts across the whole organisation. So, and that's something that we're doing locally. We're looking at how we can actually kind of skill up our whole workforce to really understand what's the impact of health inequalities on the sector, and how can we all work together to really tackle those, as I say, in that kind of purposeful and proactive way.
Perfect. Thank you. So moving from the ambulance sector, although I now feel I'm kind of spanning some divide, I don't know, kind of into the mental health kind of, you know, spheres of thinking. So David, we know that the COVID pandemic had an impact in terms of mental health, both increasing the awareness about some of the issues, but also increasing demand. And SLAM has been doing exciting work in the space of recovery. So would you be able to tell us more, please?
Yeah, let's see what these mics do. It's a bit like being in a Jesus Mary Chain concert for the teenagers here who won't know that lot, but let's hope there's no more feedback. So inequalities, I'm going to talk to you a bit about a programme called South London Listens and some of the things that we've actually done as a result of this. So at the end of the first wave of COVID, it was obviously clear how COVID was impacting in an inequitable way. And really, across South London, it's a very deprived, it has pockets of deprived areas. It has some really affluent areas, so it's a real mixed area. But we launched a programme, so it wasn't just a typical NHS programme around, okay, well, what can we do? We felt that we got the 3 mental health trusts together across South London, both the ICSs, all the local authorities across South London, and looked at what can we do. And agreed that we need to be listening to what local communities are saying. So we engaged with a partner called Citizens UK. Those of you who work with them will know how fantastic they are. Those of you who haven't, I would suggest checking them out. They're a really great organisation for engaging local communities. So we embarked on a 4-month listening programme, and during that period we heard from over 6,000 people. And a lot of this was online, and 150 different organisations that we worked with. And from those conversations over 4 months, we heard 4 real key themes. One was work and wages, and how low wages were a key factor in inequalities and poor health, mental health and physical health. We heard about social isolation and loneliness. We heard the importance of children's mental health, And we also heard about the barriers faced by migrants and refugees. So what have we done? So on work and wages, that's gone off again, hasn't it? On work and wages, we've made sure now all of the trusts across South London are signed up to the living wage, paying the London living wage. If you work in an organisation, you're not paying the living wage, you should be. I urge you to contact the Living Wage Foundation, really helpful organisation who will help you get accredited and to pay your staff and contractors, get it in all your contractors to make sure that we pay people the decent wage. We have uplifted over 3,000 people now to receive the London living wage across South London, and that's had a real impact in terms of what families and people can do. We heard about social isolation and how that really impacts. So we produced with citizens what we call a Be Well programme, and with local communities. We set up over 50 Be Well hubs to promote mental and physical health care and train 500 people. There's regularly 1,000 people accessing these hubs. They're all over the area. It's the place. They're not just health. They're in libraries, they're in community centres, they're in GP surgeries. Digital exclusion is part of that. And with a local charity, we've given away over 10,000 old laptops, phones, screens, all sorts of computer equipment to disadvantaged communities, refugees, and young carers, etc. So we're partnered with a local charity to do that. I talked about CAMS and the importance of children and young people. There are big waiting lists. So what we've heard from people was they wanted support whilst they were waiting. We've set up what we call a virtual waiting room where people get support as soon as they're referred in. They can see where they are on the list. They can get support and information and resources that are all on a website, and they can access a really fantastic organisation called Couth, where they get online support and advice and some therapy before their appointments are done. And then finally, what we've done is doubled the number of GP practices who are offering safe services to refugees. Really important that people feel that they can access health without any fear about being questioned around what their status is. We know that that's a real inequality. So we've doubled that. We've now got over 200 and another 80 signed up last month. There is a website called South London Listens that you can see all of the information that I said on there. So this is happening, it's real, it can be done. It's I won't say it's easy, but it's not really, really difficult. So real practical things that can be done.
Thank you, and thank you for stressing the need to focus on staff as well as, I mean, it sometimes feels like an either or, patients or staff, but actually health inequalities also applies to really both of those population groups, so thank you. Let's come to you, James. You're going to take us into the world of actually partnership working across 3 organisations in the community.
Thank you. So, yeah, my name's James Wilson. I work for Midland South Essex Community Collaborative, and that's the feedback. For the past couple of years, I've been facilitating how free community provider organisations come together to deliver better care, taking their lanyards off and working as one. The Midland South Essex Community Collaborative serves a population of 1.2 million across Midland South Essex ICS footprint. Historically, the free community providers were commissioned by 5 CCGs, which unintentionally baked in mass inequity of provision across our patch, and we've been working for the past 2 years to really tackle how we can improve outcomes together and provide that improved service offer. I think the world of collaboration that I've been working in for the past couple of years really polarises both the challenges and the opportunities when looking through health inequalities lens. To focus on 3 areas of challenge that certainly we've experienced and I think others in the collaboration world have. The first is data, the second is duplication, and the third is meaningful delivery. So to pick up on data, we know across any projects where you're trying to work across more than one organisation, the sharing of data, ensuring that you've got that meaningful data that actually can really focus you in on the areas that you need to address, and also ensure that there's success in terms of where you're going in terms of the delivery against that is really challenging. Duplication, I think, is a key one. Collaboratives have been set up across the country with common aims to improve outcomes, working across sectors, within sectors and across boundaries. When you're looking through the lens of health inequalities, I think for collaboratives, it's really key that you're cognizant of the other work that's going on in that system. That might be through the system lens, it might be through the organisational lens, it might be through the service lens, and ensuring when you're looking to tackle health inequalities through the collaborative lens that you're not duplicating what's already there and you're adding value. Really using and harnessing those relationships that you've got through the collaboration to ensure that where you focus in on through the strength and the power of collaboratives really makes the impact. And then in terms of meaningful delivery, and I used delivery, so I had 3 Ds for my challenges there, but I think it was really about meaningful delivery. Where we set up our collaborative a couple of years ago, we hard baked in the ambition that as we look to transform and improve our services, that we would tackle health inequalities as part and parcel of that. It's not a project that we've done on the side because someone thought it would be a good idea. And I think having that meaningful and true intent at the start is really important, but really difficult to do and ensure you've still got that finger on the pulse. In terms of opportunities, collaborations bring many opportunities. I'm just going to focus on 3 areas. So the first is scale, the second is knowledge and expertise, and the third is innovation. In terms of scale, the scale of providers coming together gives a greater opportunity for investment, a greater opportunity to to access resources, a greater opportunity sometimes to take a bit more risk when working across multiple organisations. For example, in terms of where we've accessed different resources, we repurposed one of our vaccination vans that had been doing great work during COVID, going out supporting hard-to-reach communities to provide vaccines. It was working for one organisation. We repurposed that to focus for our respiratory teams in those areas where there were deprived communities, ensuring that those communities could access that important respiratory provision. In terms of knowledge and expertise, by the definition of working across a collaborative, you've got that wider pool of knowledge and expertise, those passionate leaders, those patient leaders within that you can tap into, and the best practice that's going on across the multiple organisations. So you can test and learn and then roll out, something that we've been really passionately doing across the Mid South Essex Collaborative, not reinventing the wheel, not having to repilot, but looking at how we can take the best practice and roll that out. For example, the work we've been doing with a PCN in diabetes, focusing on 500 people who historically had not been accessing their annual diabetes check, proactively targeting those individuals to get them that necessary support, and then looking at how we roll that out across the whole 1.2 million population that we serve. And the final one is about innovation. So innovation needs investment, and by working through the collaborative lens, there's a greater opportunity to explore where there's investment opportunities. A number of the national bid submissions are requiring us to come together as a collaborative to do that. But I also think it allows you to reframe some of those wicked problems when taking your head out of an organisational kind of way of thinking and looking at really what's in the best interest of the patient. Something that we've tackled through looking at our children, young people, autism, long waits, where with co-production at its heart, we've designed with our teams a way of working to have a single pathway, an online portal that can make best use of the limited specialist resource we've got, can keep families and patients informed about what's going on, but also as part of that, baking in a proactive way so we can tackle those inequalities and proactively support those individuals who need it most. So in summary, I think collaboration is going to be the future for how we can really make a difference and tackle inequalities.
And that notion of opportunity, yes, it's challenging, but I guess at any level that you're working, whether it's providing collaboratives, whether you're looking at the integrated care systems, just partnering across, or all the multiple partners, some of the concepts there apply to that as well. So thank you. Shall we come to the audience then? So you've come here, and I can see in the audience that there are different people who are already at different stages. So I know some great work happening in terms of academies or apprenticeships and all sorts of other things. So what are the questions you're holding in terms of really using a health inequalities approach to recovery? We'll start with Fatima.
As you all know, I can't bear a silence. I'll be the first one to dip my toe in the water. So thank you for a really fantastic presentation and session. My sort of question is, many of you discussed or reflected on the wider determinants of health, and a key ally in that is working with the local authorities and influencing things like housing, education, etc. In the fight against inequality, particularly in the context of elective recovery, what do you think are the opportunities of working with the combined authority or with local government to address and support people who are waiting to access care that may experience inequality or social injustice in society right now?
See the hands for anyone else who wanted to come in. We've got another question as well. Colleagues, so who wants to take that one? Or I can certainly make it. Do you want to do that?
I can give you an example of something we're doing with schools, which is really, really important. There are some fantastic schools in South East London and some really dynamic and impressive head teachers who have taken this issue about inequalities and working not just with the children but with parents and how they're supporting that. So recognising what's happening with children. You know, you hear from teachers around that go out and they're buying children's shoes because they're coming with no shoes, or shoes that are 2 sizes too small, and engaging local communities around it. And we brought them in as part of this as well. I say brought them in, they've been doing really great work. It's not, you know, it's nothing to do with us, but it just shows the impact that has. This is not health, this is all of those other things: education, work, housing. It's all those which are massive determinants of health. Yeah.
I was going to come in. So I guess basically the quick answer also is that the councils and the government, there are multi-layers in terms of their composition. So think in terms of all the different aspects. So if we look at a system, often social care actually needs a lot of focus to get a healthy functioning system. And actually the council also has levers into wider determinants, but also that. Also in terms of the political arena, and the key bit for me is public health, who are already doing a lot of work already, both in terms of the case for change, links into community, already working with partners, including the NHS. Some people are joint appointments across both. So wherever you are, have a look, reach in, and you will find allies. In you know, one, if not lots of those, already doing great work. Sorry, I've just seen 5 hands go up, but I think yours was next, so let's come to you.
Thank you. Peter from Dorset. I'm a Chief Information Officer. At our board, we've had many conversations about how to bring inclusion into elective recovery choices, if you like. And I was really struck by the practicalities of what you said, Professor Patel, if you don't mind me asking a direct question. The heart algorithm, it just seems so innovative. And I guess my question is that somewhere credited by the NHS or approved or supported at a level where it can be, if you like, safely spread out? Because you then went on to talk about social values, I think, social value judgments. And of course, you know, all these algorithms have a bias written in by the people that wrote them. And I guess there's something about just checking against all of that before we adopt. I think all organisations should adopt something like that, but how do you spread something, I guess, is what I'm trying to tease out. Something like that.
Yeah, I'll try to answer it very quickly. So I think we have lots of factors within the algorithm. We haven't weighted any of them, but of course you can weight them to see if you start to make traction at a population health level. So this is an iterative tool that we're evaluating as we go along. But the baseline utilisation for scheduling healthcare is indisputably delivering the NHS constitution and performance. So it's widely acceptable. In fact, we've had colleagues at NHS England supporting rollout. So it's been fairly well accepted in terms of utilisation. We just have a small team to roll it out at the moment at a practical level, but we're happy to support rollout. In terms of extension into social value judgments, we've explored that to show the art of the possible. So when Jeremy Hunt turns around and says, I want to get everybody who's able to work but on a waiting list and can't work, can you do that? And we've said to his advisors, yes, we can do it, but it needs a wider societal debate to invoke those conversations.
Kiran, is it right that you're also working on improving data quality as as well. So as part of your efforts, there's something about accepting some of the limitations if we are in a system that is already structurally unequal. And I think some of your work is that, and the other is the hearts and minds work, because there's quite a debate in terms of, oh, why do we need to focus on this, and actually is it fair? So
Yeah, I think it's really interesting too. So scientifically, we know that actually deprivation isn't a linear gradient when it comes to health outcomes, and that varies across the country as well. So comparing our data to colleagues in Oxford and Bradford will be really interesting to see what drives health outcomes and how do you weight things. And I think it has to be locally tailored. So population health management using a tool like this becomes really interesting because the public ultimately wants to have equity of outcome across the country, not just in the local healthcare economy that it resides in.
thank you. There's so much more to unpick, isn't there? And exactly that. But I know we've got a colleague there waiting.
So I'm chair of Coventry White Partnership Trust, and as an ex-goalkeeper, I'm used to projecting my voice to get the goalkeeper to centre forward out of my way. So I love the examples of health inequalities and how to improve how we get people to access our services better, like Kiran's examples. I think the moral case everybody in this room, I'm absolutely sure gets. We need to be better at persuading the Treasury that Kiran's model delivers savings back to the system, back to the Treasury. How do we capture, because I also heard the word innovation, we need to invest more. If we could persuade the Treasury that innovation delivers capital savings and adds to GDP, we will start winning the debate. At the moment, we're losing the debate because all the health sectors we've had so far said, we're giving you more money, we're giving you more money. That more money always translates to maybe £1 investment in the NHS to a £9 return to the Treasury. How can we put that case better to make sure we get the capital, we get the workforce, we get the investment in prevention?
Thank you. So actually, I might come to both James and Ruth, because I think there's something about your question about how do we make that case better to Treasury, but I think there's something about in the work that you're doing for partners and ambulance services as well. How do we convince people? Because actually, I know that economic modelling exists. I was at a presentation only a few weeks ago where Professor Owolabi was making the case in terms of people, moral case, economic case. How are you making the case, and how do we make the case more effectively?
So, is that working? Yes, it is. It's a really good question, and I mean, it's from an ambulance service perspective, it is hard because all that you see in the media is how much demand we're facing. So I think certainly from our perspective, it's about making those partnerships, and it's about making the case actually for our role, because generally speaking, the ambulance service isn't necessarily considered in this space. I think we aren't necessarily at the same stage as others in the room. I think we're relatively new to the running, so for us, I think it's about articulating actually what can we offer, and that's both at the national level and at the local level, and it's what I'm trying to do at both levels, I suppose. It's broadly speaking actually what can we offer, but then at that local level, it's being able to drill it right down into something really specific, and that comes back to that data piece. Actually, what are the needs of our populations? Who do we need to be focusing on here in terms of the inequalities agenda? What do we need to be doing? Who do we need to be working with? And then it's bringing all that together into that kind of real evaluation piece, because, I mean, I don't know about others in the room, but I think the ambulance service is really good at putting things in place, but they're not necessarily understanding the impact of those. So we need to get much better at being able to evidence that impact. And I think when we can start to do that, then we can really start to demonstrate the difference that we're making.
One of the challenges when looking through the innovations we've faced in the community has always been the governance that we have, where you have a great idea and something that you know works, but then the way that we're constructing the NHS means that there's lots of people who want to have a view and an opinion on whether that's the right thing to do for their organisation or their constituent part. So I think something that we've been really trying to push is to be able to, through that wider partnership or through the collaborative lens, is to make those decisions once, which means there's less hoops to jump through. And I think the more we can do that, the more likely we are to really drive innovation across the sector. So I think that's going to be key, and we're going to have to be a bit more comfortable with the grey and the risk, and we're going to have to take a bit more of a risk appetite with us in terms of if we're going to really drive these innovations, because inherently sometimes they go wrong, or they're not necessarily going to deliver what we're expecting, and we'll never get that perfect data set to tell us that we're on track or that it's the right thing to do. So we have to be, the 80-20 rule here I think really applies.
Is there anything that you wanted to add? Because it looks like you might want to say something. That might be the very reason for some of the work that you do. And I don't know if there's something in terms of the living wage as well. How do you convince people to back these things when, actually we're in such a difficult, challenging, financially challenged circumstance?
Yes, I think Jackdaw hit the nail on the head. How do you make a case for this being a wise investment? Well, I'd say pent-up demand is expensive, isn't it, right? So if you really want to move upstream from that expensive pent-up demand and unmet need, you've got to meet it upstream. So you've got to provide interventions to people who need them most. And furthermore, I think when you talk about prevention, actually I don't like the word prevention. I think we need to get into health preservation. So how do you keep people healthy for as long as possible with the right biological, social and psychological interventions? And that really gets us into the exciting space about saying, how do you preserve that health and wellness for people at an individual and a macro level? That's where we need to make our transition for investment. And the case for change is just indisputable, isn't it, in terms of return on investment? But we've got to make the transition from all the expensive stuff we've got to deal with now to where we really want to be in the future. So some of the stuff we heard this morning was really spot on.
How do we convince people to pay the living wage? So I sit on the London Mayor's board for this, and I have heard some local authorities say that they don't want to do this because it's a Labour Mayor's policy, which is, disgraceful. But people do say, oh, well, it's going to cost us more money, and it will cost more money. But, we pay everybody else an upgrade, and there is no doubt that paying people a decent living wage and giving them living hours to be able to do it has a positive impact on health outcomes. We've got to move more towards prevention around things. So there's some things around as well. If you're not paying it, your competitors are paying it, and you're going to start losing out. It's a struggle to get staff anyway. So you pay the living wage, you're going to be at an advantage. Amazon are all over the place. You see adverts on TV that look fantastic and they work there. And if some of our staff are dropping below those, well then we're never going to be able to do some of the things. So I think the case speaks for itself, and you've just got to face up to it and start to address it.
And I guess I would probably make a plug for two things, because I think exactly as colleagues are saying, so there's enough resource out there in terms of the case for change, and I see colleagues from the Health Foundation here. There's something about the Real Centre, part of the Health Foundation, which I think is doing really good work in terms of some of the modelling. And also, actually, the King's Fund published a report only a few days ago making the case in terms of some of this and studying 3 examples, going, why isn't there more being done systematically across the board in terms of recovery equitably? And there's something also lacking, I think, in terms of a national effort for Case for Change, bringing together all of that in a concerted way. I think that's what it was signalling. And I think that's what you said previously as well, Kiran, in terms of we've got the case for change, now it's time for action. That might need us to bring it all together. And again, public health have so many national frameworks, tools to get the data to make the case. So yeah, I think that the challenge is implementing together. Okay, who else? I kind of, one, two, three. I think you got there first. So shall we come to you both and then we'll come across to you?
Thanks. Sean Linton from the Sunday Times. I wanted to ask Kiran a question. You mentioned the work you're doing really well. It was really interesting. But I've heard you say all this before, and we haven't got this rolled out everywhere. And listening to the conversation this morning, I'm just thinking, we're talking about inequalities and people are deteriorating on the waiting list. Are you seeing patients deteriorate on the waiting list who are also from the lowest deprivation, who are unequal to others, and so we've got an inequality problem in terms of actually people being harmed whilst they wait? Is that what you're seeing?
Yeah, Sean, I'm going to be diplomatic here to answer this one. I think the answer to your question is yes, across the NHS we're seeing that. Because if you look at just the changes in life expectancy and the gap widening, people are dying earlier. So we're seeing a reversal in that trend at a macro level. At a micro level, at an organisational level, it's incumbent upon us to make sure that we review harms. Now, we're very good at looking at harm after the event has happened. We are less good at looking at harm proactively through an assurance lens. So certainly at our organisation, we've invoked clinical harm reviews from the point of view of surveillance to see if we need to do something. I'll give you a concrete example. Cardiac surgery waiting lists. We know that these are growing, and they're growing because people need urgent cardiac surgery. They're being admitted to hospital because they've got unstable angina and they need to come off an elective list and get done as an emergency. So we're using that data. So if somebody turns up to A&E because they're on a cardiac surgery waiting list with angina, they don't get packaged up and get sent home in our place. Actually, they'll get expedited elective care. So we're moving patients away from the front door into an elective pathway rather than repeated A&E attendances. And I'm sure this is just one of the factors driving urgent and emergency care demand going upwards. So we've got to get better at surveillance and harm reviews to get into a more proactive place. And as soon as you see that dial moving, before you hit statistical process control, you've got to intervene and act on it. So for cardiac surgery, that example, what I've done is to say we must have ring-fence beds. We need to clear this inpatient waiting list as a priority. These people are more likely to die than anybody else on those waiting lists. And you've got to make really instantaneous decisions to move the dials and move operational activity to address this. Otherwise, people will die on their waiting lists. And we know people are dying on waiting lists.
Hi there, James Elman from Health Service Journal. Sorry, Kiran, another one for you. You spoke about opening the can of worms on how social value judgments are used to prioritise waiting lists, and that debate needs to be had with the public. But do you feel like it's one within the NHS? Because some of the comments beneath stories that I've written, certainly about health inequalities, would suggest on HSJ would suggest that's not quite one yet.
Yeah, James, and I have to thank you for opening that can of worms with me, because it was interesting, wasn't it? You know, we made the point because politicians were out there saying, let's get all the NHS workers back to work if they're waiting for healthcare. Let's get people of working age activity back to work if they're on a waiting list. And of course you can do that because the NHS is rich with data and we've collected that data. So you can do it, but of course, what does the public think about that happening? You know, why is an NHS worker more important than a bus driver? You know, big question, isn't it? So these are ethical and moral debates. And the work we did with Ipsos Mori opened up that can of worms. There is a diversity of view across there. But the other interesting thing Ipsos Mori exposed for us was that the public don't understand how NHS waiting lists function. And more importantly, they don't understand that there is a variation across the country. When we talk about 18 weeks, you know, Joe in Middlesbrough and Joe in Cornwall think they're both going to wait the same amount of time. They have no idea about the unwarranted variation that exists across the NHS that is within our gift to resolve, let alone moving into the social value judgment territory. But, you know, one reason why I'm passionate about opening this can of worms is let's take the most important social determinant of health, and that's having a child being able to read by the age of 5. Now, if a child under the age of 5 is on a waiting list and is deprived of those early years of education, they'll be affected for life, full stop, indisputable evidence. So actually, can we pick out those kids who are being deprived in education? I think that's a moral obligation for the NHS to do that. And then we can come on to the can of worms about the other factors.
And I think some of this is getting beneath the surface. So these are debates that will likely and need to continue, actually. So thank you. Shall we come to Marianne? Let's come to you. I think it's probably last audience question, and then we'll do a round across our panel.
Hi, Mary-Anne Farrow. I'm a medical director at Health Innovation, Kent, Surrey and Sussex. One of the points I just wanted to talk about a little bit more was around ethnicity data and the challenges of that. We know that in COVID, clearly ethnicity was a strong component in terms of poorer health outcomes, but we also know across organisations how difficult it is to have good ethnicity data. So I guess I'm interested to hear how people are managing that, given that clinicians often don't want to ask the question and patients often don't feel safe enough to answer the question. So how are we going to manage those gaps in the data so that we, when we move to things like Kiran's tool or other innovations, you know, we're actually addressing some of the biases that are within the system?
Thank you. And a huge confusion at the moment, isn't it, in the health and care system? And I know we're looking at that in terms of ED&I and health inequalities, the overlap and the differences between them. David, shall we come to you for some thoughts?
Yeah. So, health inequalities in mental health. You're over 5 times more likely if you're a young black man to be detained under the Mental Health Act than if you are a white man. And this is, we're perpetuating inequalities that we see in the rest of the society. You're more likely to be brought in by police on a section 136 if you're black in a police van than you are if you're white. You will come in an ambulance. So there's these inequalities, inequities that are baked in, and you can only start to address some of those if you know what some of those things happening. So we know some of those things happening. So we determined that we addressing that as in SLAM. That's a central part of our strategy around inequalities and equity. And we've made it mandatory that you collect ethnicity data because the data, as you say, is not always great. And people sometimes think they can't ask, or they don't fill in the field, or they just put other. And so we're not getting the right thing. So we've made that a central thing and around the organisation of asking people. So we can see that by incidents as well. We can see it by the number of restraints that happen. So you've got to be able to see it to everything. I think it's really, really important that all organisations are really collecting this. You made an important point there. Supporting staff to be able to ask it in a way which doesn't feel that they are being intrusive, and being able to explain why we are collecting that. And it's not collecting it for any surveillance information, it's collecting it to try and improve what we're trying to do.
Thank you. I might just hand over to you very quickly to ask, actually, how does that manifest in the ambulance sector? And then also maybe a word in terms of actually, and when you're working across partnerships, how do you take into account diversity and inclusion as well as health inequalities?
Such an important point, and ethnicity is not well collected in the ambulance service. I think there's probably 2 things that we need to look at, and we've just brought in, I'm nodding because she's sitting there, we've just brought a public health analyst into the organisation, which has been really, really interesting, as I said, to kind of tell that story behind the data. But ethnicity is not something that we can really say much about because we just don't have the quality. So I think there's two pieces around it. One is that kind of training and education piece for our staff, because let's face it, I mean, it's part of person-centred care. So absolutely, that's something that we need to do. We're also looking at electronic solutions as well, because obviously there will be some situations for the ambulance service where it isn't possible to collect that information. So we're looking at electronic solutions to try and be able to kind of fill it in from other sources as well. But yeah, really important point, and absolutely something that we need to be looking at, because we just can't tell that story without it. And I would recommend actually going to speak to Verity at some point today, because she's done some really interesting things with our data, which I can't cover now. But yeah, she's downstairs in the exhibition hall, so go and speak to her.
Thank you. And a quick word about workforce, ED&I.
I guess go back to one of my first Ds earlier. When trying to work across different systems, it's one thing collecting it, but if you collect it in a slightly different way, then trying to actually stitch it together and compare and understand what it means when you're working as one is really challenging. I guess the opportunity bit that certainly we've got is we've got some really great best practice in one of our 3 providers that we're kind of beg, stealing and borrowing to make sure that we actually roll out and learn from that organisation. But it really comes back to the basics of what we're collecting, and are we apples and apples, and asking the question in the same way is essential.
Thank you. So I guess we've only got a few minutes left, and thank you for the rich and wide-ranging questions. The title of the whole session is about how do we take a health inequalities approach, how do we really embed that into recovery. So if I quickly whiz round and give our panel members a final word. So what do you think is the one thing that you think people can do, a practical thing that can make a difference going from today? Shall I start with you, James, and then come round this way?
I guess that putting it on the agenda and talking about it, because I think that this is going to come from great leadership. So having it on the agenda at the forefront is going to be key. And that's my one. Sorry, I won't go more than one.
And keeping it on the agenda, because there's that risk as things get more and more pressured, these are the things that are going to drop off. So if there's one thing we can do over winter, keeping it on the agenda, please, let's do that.
I would say pay the living wage. If you don't, I think that's really, really important. I'll do that as my one thing.
Absolutely, get the basics right. Thank you.
That's a really hard question. I don't have one thing. I think collaboration for me is really, really key. Keeping it on the agenda, absolutely. One of the things that we haven't discussed much today is in terms of kind of involving the community in our conversations as well. And I think that's super, super important in terms of that collaboration piece. I could go on, but I won't.
Absolutely, we cannot do it without the community. Absolutely.
Yes, I think to marry that comment up, I think we've got to focus on health outcomes and what drives them. And within that, what we often ignore is health-seeking behaviour of the populations we have. So just accept that health-seeking behaviour and design your services around them, rather than expecting everybody to conform to the complexity of services that we design, which is very patriarchal, and we think people will go to where we design it. They absolutely won't. We've heard about the elderly needing better access to primary care in the way that they want access and face-to-face. So let's just accept that, design that service, and make a slow transition towards the change in health-seeking behaviour.
Lovely, thank you. There's so much in just that, something about shifting power, as well as accepting, as well as so much exists, as well as let's just do it. So for me, I guess, holding all of that, just to say thank you to fellow panellists for joining today in this conversation, and thank you to all of you for choosing to